Welcome to ReserveConnect Forums. From the Reserve Organization of America, the voice of the National Guard and Reserve. ROA is your advocate on Capitol Hill, in the Pentagon, and in communities across America, empowering our reserve force and families to thrive. Every second Tuesday, ReserveConnect Forums connect Reserve Component service members, veterans, and their families with experts, resources, and real solutions, covering employment, health and fitness, family life, education, and the national security issues that matter most. We know the life of America's Reserve, and we're glad you're here. Let's get started.
Good afternoon, everyone. I am your host today for our inaugural Reserve Connect webinar on behavioral health challenges of the reserve component. I'm Steve Minyard, and along with everyone else here at ROA, we get the challenges of reserve component service. Myself, I've got about 3 decades of service in the Army and the Army Reserve, and joined by all of our compatriots here today. Want to give a quick shout out before we get started to TTA Empire and U.S. Family Health for joining us today. And Josephine, I'm going to pin you and bring you on in. Great to see you here. All right, there we go. All right, welcome everyone. All right, hey, good stuff. Hey, so today we're going to be jumping into a topic that really hasn't gotten enough attention from a reserve-specific standpoint. Whether you are working through challenges as a reserve component member and adjusting, simply coming from drill on a Sunday evening and jumping into college or work on a Monday morning, whether you're deployed or you're a family member and your family member is deployed, they're overseas, they're at the cutting edge of national security on freedom's front line, but you are working through access to behavioral health resources or even medical resources, some of what we're going to talk about today, before, during, and after that period of active duty service. This talk is for you, and I'll add too, as again someone that did some good service in the Army Reserve. If you are a leader, you've got more than one stripe on your shoulder, on your collar. Probably dated myself with that comment. Then this is also for you to save these resources. We're going to be recording. We are recording today, and being prepared to share those with your subordinates and folks that you will lead. And if you are in the reserve component and not a leader, you will be. So these are some good resources to have. Just a couple of ground rules before we get started. If you have your camera on, just be aware that we are recording this. So if you want to turn off your camera, that is highly encouraged. If you have any questions, you'll notice that there is a chat function here. So please drop those questions in. We are planning on having some time for questions, but if we don't get to them, then we will take the questions, send them out to our panelists today, and we will get them answered. If you registered, then we've got your contact information to get back with you. If it is a topic that we need to be advocating for, then we will look at that as a piece of our advocacy here at ROA. So we really appreciate any feedback that you have for this webinar as we go through today. So I'm going to do a quick round robin of our 4 amazing panelists that we have today, or 5, actually 4 panel members plus myself on here today. So as I go through here, panelists, if y'all could just give a quick introduction, and then we'll jump into our content and talk about data and statistics. So first, Josephine Gray, I turn it over to you quickly, Josephine.
Thank you, Steve. Good afternoon, everyone, and thank you for joining us. We really do appreciate your time today. So I am a retired warrant officer from the U.S. Army, 24 years active duty. I work in government relations with U.S. Family Health Plan. And I have experience with military healthcare close to 30 years now. And happy to say I'm finishing a dissertation on the mental health challenges for combat veterans. So this is very near and dear to my heart. Thank you for joining us.
Oh, thank you. Tim, I'll pass it over to you for a quick intro.
Good afternoon, everyone. Stephen, thank you. My name is Timothy Awajobi. I'm a Air Force veteran. My last base station was 514th FSS Reserve Base here in New Jersey. I have a lot of experience with dealing with reservists and guardsmen in the state of New Jersey. Run a nonprofit for veterans, TT Empire Incorporated. We're a 501c3 nonprofit giving back to veterans, military families, folks on mental health, advocacy, research, and housing. Just like my colleague Josephine, I'm also getting my PhD in higher ed administration, focusing on mental health, outreach for student veterans, and looking to improvise any way, shape, or form we can help you guys. So thanks for joining this call, everyone.
All right. And Rosemarie, over to you.
Hi, good afternoon, everyone. I'm Rosemary Livingston. I'm a licensed clinical social worker. I'm the Director of Behavioral Health for U.S. Family Health Plan. So I oversee the mental health benefits for the plan, the Behavioral Health Care Management Program, and also our special needs programs.
Awesome. Thank you, Rosemary. And finally, over to you, Jason.
All right, hey everybody. First of all, I want to apologize. Having a little bit of technical difficulties. Don't know why my camera is not working. But my name is Jason Prosser. I am the Director of Marketing for U.S. Family Health Plan. I am also retired, 20 years Army active duty and a combat vet. So very well aware of a lot of the processes that go on within the military and what we're doing today. And I'm happy to be able to present today talking about early eligibility and using your TAMP benefits. So welcome, everybody.
All right, good stuff. And if y'all are joining us and you are currently serving reserve component member, TAMP and early eligibility are absolutely huge to be able to enable you or your families, and if you're a family member, to enable you to have access to the health care that you have earned and deserve. So first, we're going to start off with some of the statistics and data. And our first guest will be Josephine jumping into that. For context for everybody that is on, our reserve components are about 40% of the total force. So we have about 1 million currently serving members, and that includes the IRR. We've got another 1 million family members that accompany them through their service. And then we have another 5 to 8 million veterans that are somewhere connected to the reserve component, whether they're through ROTC or they've done a stint in the IRR or in the reserve component. That's a huge population of folks, and all of those are folks that are within the realm of ROA's advocacy. But to drill down a little bit more into the statistics of behavioral health issues, I'll turn it over to you, Josephine, and you've got the mic.
Thank you, Steve. Yeah, so as we all know, statistical data is always and forever changing. And when it comes to healthcare and behavioral health, there's all kinds of information out there. So we wanted to equip you with the most recent and current information. According to the Department of Veteran Affairs Health Services Department, reintegrating from OEF, Operation Enduring Freedom, and Afghanistan, or OIF, severe mental health and readjustment challenges are prevalent, as we all may or may not know. And according to the Department of VA, about 36.9% of these OEF, OIF veterans from Afghanistan as well that use the VA healthcare have received a mental health diagnosis. So you may or may not be in that category, or you may know a battle buddy that's in that category. In addition, the prevalence of core mental health conditions appear at higher rates when integrating back into civilian life in comparison to the general public. When it comes to PTSD, post-traumatic stress disorder, a lot of us veterans on here may or may not have had situations where you have been diagnosed with PTSD or not diagnosed with PTSD. And also, it doesn't necessarily mean it's just for veterans. I mean, civilians also have PTSD. But clinical data shows that currently about 21.8% to 23%, so that's their variance, 21 to 23% of these veterans using the VA are diagnosed with some sort of PTSD, some form of PTSD. And there's a positive screening rate of 15.7% of these veterans in comparison to 10.9 of these veterans that were not deployed in OIF, or Afghanistan. And as you all know, there are several variations of deployment missions. We're just honing in on these three in particular. When we talk about depression and anxiety, and I know Rosemary is going to get into detail into these topics, major depression affects about 17.4% to 24% of our force of these veterans, and the anxiety is about 11.1%. And last but definitely not least, the substance abuse. So the use of substance abuse, we're talking alcohol, narcotics, controlled substances. Personnel that have been deployed or returning from a deployment, it's an approximate 14.5% of abuse to help and cope with these situations as a coping method with using substance abuse in comparison to the 6% of our veterans that were not deployed. So I encourage you to pass this information along. I implore you to read up and educate yourself on the statistical analysis that's out there and help your battle buddy out. And thank you, Steve. I'll take it over to you.
Thank you, Josephine. Tremendously appreciate it. So next, we're gonna pivot and really dive into some of the specific issues that our folks that are in the reserve component work through. One of the coolest things that I really nerded out as soon as Rosemary showed this on the slides was the acknowledgement that it is a bit of a pivot to go from drill weekend into whatever you've got on that Monday. I blew hot and cold during my career, whether I looked forward to go into the drill weekend. When I was a operations sergeant major, I loved it. When I was an E4, maybe not so much because I wasn't running very much. But that is an adjustment. And so she's going to hit on that as well as the adjustment of coming from, think of the folks that are over in Kuwait. They deployed. It was not a combat zone with many of the folks that went over there, and now they are coming back from an area that is very, very active. Yeah, how is that paradigm work and adjusting coming from that coming into the back into the country? So, Rosemary, I will turn it over to you, and I'll get your slides teed up here as well.
Thank you, Steve.
All right, and over to you.
All right, great. So I'm going to take the next few minutes to walk us through navigating the terrain of post-deployment mental health and really ways to overcome some of the challenges that reservists and their families face in accessing care and specifically in mental health care. And we can move to the next slide. And just a little bit about myself briefly, I am a licensed clinical social worker. I have a master's in social work from Fordham University here in New York City. I'm the director of behavioral health at US Family Health Plan. So I explained in my intro that I oversee our mental health benefits for the plan. And I have 15 years, probably over that now, of experience working with children, families, and that includes military families. I'm the mother of 2 daughters who have a lot of energy. I'm a lifelong Red Sox fan for sure, and have to plug the Knicks. Go Knicks. And it's not going to be Knicks in 4, unfortunately, but I can still dream, right? Next slide. So I want to start strong with this statement. Mental health treatment is a clinical intervention and not a personal failing. And when we're proactive in seeking our mental health treatment, there are many benefits. So we know that engaging in mental health treatment can reduce risk of physical problems. So it definitely has an impact on our health, our physical health. Mental health treatment can help us build coping skills to manage triggers as they come up. And engaging in addiction treatment actually increases the likelihood of long-term recovery, long-term addiction recovery. And by engaging in mental health treatment, we notice a positive impact on our relationships, our self-esteem. We can learn ways to help our children cope with their emotions more effectively. something that they may be struggling with. And engagement and mental health treatment can provide relief from mood symptoms, so anxiety, depression, symptoms of post-traumatic stress disorder, PTSD, and it can actively reduce the risk of suicide. We also know that there can be significant barriers to accessing mental health care. So that includes stigma, which we will talk a bit more about. Also, lack of availability. So finding available providers who specialize in the form of treatment that you might be seeking, having inadequate insurance coverage that maybe does not cover all of your mental health care, or having to pay significant out-of-pocket costs or co-payments, things like trying to manage a high deductible, having to obtain referrals or waiting a long time for a specific provider can be a barrier to care. And we know that even with insurance, mental health services can be costly. Like I mentioned, there can be co-payments, deductibles, pharmacy co-payments as well. And there are certainly challenges that are unique to reservists. So one is healthcare discontinuity, navigating private insurance and civilian providers because there may not always be access to a military treatment facility. And we'll talk later about the available TRICARE options. Geographic location is certainly also a challenge that can be unique to reservists. So access to care within your footprint. You may not have access to specialized treatment, like for example, military sexual trauma providers. And as we mentioned earlier, the impact of stigma and concerns about how accessing care may be perceived and whether that may impact your military or civilian career. And let's talk about how stigma may be an obstacle to care. So there's fears that one may be seen as weak, fears that others might question your decision-making capability, embarrassment for seeking mental health treatment, an apprehension that seeking that treatment might somehow impact your career. And there's this internalized messaging that seeking support is somehow seen as a weakness. And this is an overview of the different types of stigma. And the formal definition of stigma is actually a mark of disgrace. And this is something that perpetuates kind of across this feedback loop. So it's broken down into self-stigma or critical thoughts about oneself. And then that feeds into this notion of anticipated stigma, a fear of prejudice, which then can feed into public stigma and concern about discrimination. And how do we overcome stigma? So in our day-to-day interactions, one of the most important ways that we can overcome that is normalizing conversations about mental health and addiction, trying to connect with supportive people, and really using respectful language when we're talking about mental health. And I think that we don't always think about this piece. And so instead of saying something like, I feel like a common thing to hear is, I have such ADD right now. Instead changing our language and saying, I'm having trouble focusing. Or some people describing the weather, oh, the weather's been so bipolar this week. So trying to be more mindful and respectful, the weather's fluctuating. We're having a lot of changes. Just in being mindful about those pieces, we are trying to overcome stigma and address that. And there are some signs and symptoms that might indicate that you or a spouse or a family member, a friend might be struggling with post-deployment stress. And it's normal to experience emotional changes during this adjustment because your body and your nervous system are really shifting, being forced to shift really from a mindset of survival. And suddenly you're shifting back to an environment where those skills aren't needed anymore. You're kind of shifting back into civilian life, and those same coping skills are no longer necessary in navigating your day-to-day interactions. You may notice a change in mood and emotions. You may have increased irritability, a sudden lack of interest in activities that were once enjoyable. Maybe you loved playing golf and now that's just not doing it for you anymore. You might also notice a shift in your behavior. So you might be withdrawing socially, having a strain on relationships or tension in relationships. You might notice yourself using substances more to cope with stresses or experience a change in sleep or your appetite. And then there's also the impact of a shift in identity. So bridging these two identities, which can lead to feelings of hopelessness about the future or suicidal thoughts. And reservists are also navigating the challenges of rapid reintegration, which Steve called out earlier during our intro. So this notion of returning directly to civilian jobs and neighborhoods within days of deactivation, and an expectation to immediately resume your pre-deployment role without a decompression period. And maybe this is a bit exaggerated, but really, on Friday being in this high stress environment, over the weekend returning back to life, back to civilian life, and then being back at work again, being back in the civilian job with surrounded by people who may not understand that experience, probably don't understand that experience, and are talking about things like what they're going to order for lunch that day, while your nervous system is still active, still trying to regulate. It also means trying to find a balance in this shift in identity between military reality, where there's high structure, that unit cohesion, kind of this shared collective identity, back to civilian reality. So losing some of that structure, all of a sudden having more autonomy, trying to find your identity in that again, and maybe being confronted with people who may not understand that. So what's helpful in trying to navigate that shift? Some strategies that can be useful for adjusting during this period are finding your community. So definitely trying to connect to people who have that shared understanding, can understand your experience. Also preparing ahead of time for things like questions that may come up, or topics of conversation that you may not be comfortable with or may not be ready to respond or react to. So maybe preparing yourself with a response or figuring out a way to decline if you may not be comfortable engaging in conversation about a particular topic. Also, talking to family and friends about your experience can be helpful, even if you feel like they may not understand what you're going through. Just talking about it and sharing that with them can give them some insight into why you might need some space, why you might be struggling to interact. And taking it step by step as you adjust. There isn't a timeline, and it doesn't need to be something that you move through quickly. You're navigating new territory just like your family and friends are. And some practical daily strategies for regulating and kind of managing, supporting your mental health are prioritizing self-care, exercising, focusing on healthy sleep and eating, trying to reduce things like doom scrolling, which can be an easy way to check out in the moment, but really is an unhelpful coping mechanism when you're where you are numbing your emotions. And if you are finding yourself on social media, it's helpful to instead follow some positive or inspirational mental health content. And we also know that it's not just reservists who are impacted by mental health challenges post-deployment. So children and spouses are adjusting as well and can experience difficulty accessing mental health supports themselves. So more than 2 million children in the US have been directly affected by a parent's deployment, and parenting stress increases during that time. And so that obviously has an impact on a child's functioning. And it can be helpful to maintain routines that are familiar, kind of what is consistent and can be within your control. And some available supports for children are individual therapy, which can be in the form of talk therapy or play therapy. For younger children, play therapy is actually available for children as young as 3. You may also want to explore whether the school offers counseling as a support for your child during the school day. That can also reduce having to go out to another appointment after school or on the weekends. And if you feel like your child might benefit from additional educational or mental health support, there's the option of exploring an individualized education plan, an IEP, or a 504 plan. So that can accommodate some special needs during the school day. And participation in recreational activities is always a support, so not just socially, but is also helpful mentally and developmentally for children. And military spouses are also impacted both during and post-deployment and can experience changes in mental health. And not just spouses, really any caregiver during that time. So some of the things that may be experienced and are normal to experience are increased stress, changes in mood, and experiencing things like anxiety or depression and having difficulty adjusting. And spouses experience a shift in responsibilities. So now taking on additional roles and family obligations and what that may look like. And spouses are faced with navigating new home routines, figuring out ways to connect as a couple, maintain that connection, and anxiety or stress about future deployments. Some available supports for spouses are certainly leaning on your support system. So reaching out to family, friends, connecting with others who may have a shared experience, this unique shared experience. Also exploring resources available through Military One Source. They have a particular resource called Spouses Corner that has a lot of good support available and talks about ways to connect to care as well. Increasing self-care, utilizing respite care if that's an option, connecting to hobbies or social activities. If there's the opportunity to get out of the house, that may be a good way to do so, reconnecting back to things that you may have previously enjoyed. And also counseling in the form of individual therapy, but couples therapy as well. And as we're talking about things like counseling and therapy, I just wanted to give an overview of TRICARE mental health benefits. So mental health is a covered benefit under TRICARE, and that includes outpatient care, also more specialized treatment. So for example, trauma-focused treatment, eating disorder programs, ABA therapy for children with autism, even within that, specialized forms of care to treat PTSD, for example, or depression. And also intensive interventions, so various forms of addiction treatment and intensive outpatient programs and residential treatment programs when clinically appropriate. And with TRICARE benefits, routine outpatient therapy does not require a referral. So you can self-refer to care, and both in-person and virtual treatments are covered. And US Family Health Plan, really along with, I think, most commercial plans, offer a behavioral health care management program. So that's a free and voluntary plan benefit within US Family Health Plan. And what that is really a specialized behavioral health care manager. For our plan, those care managers are licensed clinical social workers who are available to assist with connecting to mental health treatment. So they're available to work with you one-on-one to find in-network providers and kind of work to resolve any barriers you may be experiencing in connecting to care. If you are already in a place where you're feeling stressed, overwhelmed, having difficulty navigating this time post-deployment, of course, it's hard to pick up the phone and have to do this legwork yourself. So it's helpful to lean on the support of a care manager. So on this slide, I have outlined many resources that are available nationwide and can be a support to reservists and family members. And there are also resources that can be used to kind of bridge that gap if you're in a period of deciding whether you want to connect to mental health treatment or maybe even waiting for a provider. Maybe you can't access care immediately, so you can utilize one of these resources in the meantime. And these resources offer varied levels of care. So anything from, for example, the unit chaplain who can be available during a deployment to resources like the VA apps, which you can do anonymously, kind of download and engage with one of those apps. And this is not an exhaustive list. Most states have their own resources, a lot of volunteer organizations who are available as well. And so I wanted to close out with this slide kind of emphasizing that engaging with mental health support is really at your comfort level. So as I said, there are many resources available that span the continuum, and really you decide where you feel comfortable. And if you're concerned about things like stigma or wanting to remain anonymous, then engaging in resources like downloading the VA apps or accessing the 24/7 chat on the Real Warriors campaign website might be good options for you to explore. If peer support is something that you might find helpful, just connecting with others who have a shared experience without necessarily the formality of mental health treatment, then there's the Be There program or the NAMI vet support groups that they run. And if individual or family therapy or more therapeutic treatment or addiction treatment might be the best support, best fit for you, then resources like the Stephen A. Cohen Military Family Clinics or using your mental health benefits is a great way to access care. And ending with one of my favorite quotes by the author Bernard Malamud. Without heroes, we are all plain people and don't know how far we can go. And so, just again with US Family Health Plan, we have care management support available. Most plans do. So I would encourage anyone to reach out or a resource navigator who may be available. And the courage to heal is the courage to continue. And thank you.
All right, Rosemary, thank you so very much for that. That is absolutely awesome. And really appreciate the rundown of integrating some of the real world benefits that reservists have and sometimes don't have as well, right? I think 20% of our folks in the reserve component don't have health insurance. So there are options out there. There's TRICARE Reserve Select. If you're a federal employee, obviously, we're anxiously awaiting until 2030 when that will be opened up to the federal employee folks. And just a reminder too, from ROA, we have supplement insurance that we offer through AMBA, which can take away some of those additional costs, including costs in behavioral health through our Reserve Care program. So thank you again for that, Rosemary. And we're going to pivot over to Tim, and we're going to drill down a little bit and get a little tactical too with Jason when we talked about early eligibility and TAMP. And those are TRICARE Prime programs that cover you 100%. When I was in the reserve component, some of these programs didn't exist back in a long time ago when I was a drilling reservist. So we'll get into that. The amount of information out there, I think, is not that great. Having someone that came out of the Pentagon about these, so we're excited to be able to highlight both of those as well. So Tim, I'm going to pivot over to you to talk about some of the resources and some of the great work that you do over there in New Jersey. So over to you, Tim.
So Stephen, team, Rosemary, our colleagues, thank you for everything. It's wonderful seeing you all on this amazing call. My name is Timothy Awajobi. I'm the founder and CEO of Teach Empire Incorporated. Again, we're a 501c3 nonprofit. I'm focusing on advocacy, mental health, housing, educational benefits, scholarship. You call it, you name it, we do it all. So about me, again, I'm an Air Force veteran. I'm proud, like everyone on this call, proud to wear that uniform. Some days I miss it, but you know what? We're all here for one purpose, and my purpose I know is to give back to veterans and their families. I'm a doctoral candidate. I'm getting my PhD in higher ed leadership. I teach political science, American government and politics, and basically talking about the culture and the military culture and how it's beneficial to everyone, right? There's a lot going on in our country right now, as many of us know, positively and negatively. But we stand fast, stand strong, and just keep that momentum going. I'm a veteran advocate across New Jersey. I advocate for veterans, again, old and young, big and small, doesn't matter what branch of service, we're all one unit. And I always tell people that, whether you served in Marines, Army, Air Force, Coast Guard, we're all giving back. And that giving back is giving back to those that are proud to wear that uniform and not wear the uniform. So again, we focus on mental health. Mental health is a big pillar in the veteran space. Unfortunately, many times members come out of the military and just don't know what to do or just don't know how to reach out for help. we're here to give back and advocate for mental health, whether it's PTSD, anxiety, depression. Unfortunately, in my scenario, I face a lot of PTSD from my last deployment. It wasn't easy, but you know what? We have to keep on going. Like we train in the military, you have to keep on going no matter what the obstacle is. We provide education support through all institutions across New Jersey. We navigation resources, so navigating those tools and fundamentals in the communities. We provide community partnerships and community access-based resources for primarily student veterans. So right now we're working with the Air National Guard and the Army National Guard, as well as Rutgers University ROTC. So giving these students that platform to when they do want to, enlist or commission into the Army or any other branch, they know what's going on. So, ladies and gentlemen, this is our website. Feel free to check it out on your own time, own accord. We advocate as again. We have a lot of great partnership with elected officials. This is Senator Andy Kim, who's a big advocate for veterans. I believe he did some time overseas as a foreign diplomat at that time before he became a U.S. Senator. Again, we offer a lot of workshops, mental health wellness program workshops. So our last event, which is a great success, our partner, U.S. Family Health Plan, was there. Jason Lorraine, he's under the Trump administration, was appointed for HUD. We're going to start doing veteran housing across New Jersey. And he was our keynote speaker. He's also a veteran himself, U.S. Navy. Every year we do a Navy SEAL run, a Navy SEAL Foundation. We're partnered with them. I actually deployed with a couple of SEALs in my last deployment. And every year we swim in the Hudson and we run about almost 10 miles. It's annual. We have SEALs all across the nation coming out and running with us. It's a wonderful event. It's a wonderful day to give back while running and swimming in the Hudson River. All proceeds go to not only U.S. Navy SEALs, but families across the nation that lost a SEAL. And as you can see here, this Seton Hall University, we're partnered with Seton Hall University, the ROTC program. As you see, this gentleman here commissioned into the Army. And our goal, of course, is to not only advocate for, increase of, soldiers, but to push more positive awareness. There's a lot going on with negativity about the military, and we want to change that narrative. So who we are, right? Our goal is to empower veterans as well as service members. So you guys, right? And their families through housing support. Why our work matters. So veterans don't really need charity. I always tell folks when you're donating to a charity of choice, right? There's thousands of nonprofits out there for veterans. Veterans don't want your money. They want access, they want opportunity, and they want support, right? I always tell folks that say, hey, thank you for your service. Great. But veterans really want your support. They want you to advocate for them, right? They want you to help them with mental health resources. They want you to help them out with homelessness, right? Right now, here in the great state of New Jersey, we have about 40,000 veterans, and the number might have increased. 40,000 veterans are homeless. That's, unbearable and unconstitutional. So again, veterans don't want your money. They want you to advocate for them and assist them with resources in the community. Resource navigation and veteran support. So we're here to advocate for housing assistance. So we work hand in hand with the VA, U.S. Department of Veteran Affairs, to give them guidance. We try to assist veterans with employment and workforce. A lot of vets come out of reserve, guard, active duty, and they come back home to no job. It makes no sense, but we know that we're here to be a one resource stop for them and advocate for them to get that job opportunity they want, whether it's trade or just going into a four-year institution. Mental health referrals. We're partnered with a lot of organizations here in the great state of New Jersey. A lot of big hospitals, Robert Wood Johnson to be exact, Hackensack Meridian, just to give them that platform. A lot of vets don't want to go to a mental health institution. They rather go to a hospital of choice and get that referral based. Community navigation. A lot of vets want to understand that when they transition out of the military, do they have the resources, fundamentals, and tools to navigate in the communities? Housing assistance. Again, we're trying to tackle down on housing projects in New Jersey. Right now, we're currently working on a project in Hudson County. Through our great legislators, we're able to fund those projects, get them into temporary to permanent housing, and hopefully build them homes to last forever for these veterans. Mental health and wellness. So just like my colleague, Josephine, my dissertation in my doctoral program is focusing on mental health. Mental health is one of the largest components in service and out of service. A lot of my reserve colleagues and guardsmen colleagues and active duty colleagues suffer from mental health while still wearing that uniform. I believe the stat a couple years ago, 22 a day. So 22 veterans a day commit suicide. And now I was told by my colleagues that even outside of in the uniform, we have a lot of soldiers committing suicide while wearing that uniform. That's a problem. So we're here to assist, right, with referrals, prevention, peer support, awareness, and pumping that educational background and focus. That one of the biggest components we all know is PTSD. PTSD is something that unfortunately will never go away, but there's ways to combat that. And there's programs, there's resources, there's we sent almost 6 and 7 veterans last summer to a camp, right in the middle of nowhere, I believe in Wisconsin somewhere. But guess what? Those 6 weeks, they had nothing but time to work together, do rebuilding workshops, and just build another momentum to help heal their trauma. Again, PTSD, I deal with it every single day, doesn't go away, but there's ways to cope with it in and out of uniform. So our Homes for Vets initiative, again, our partner, U.S. Family Health Plan, was there in December. We're now building homes for vets all across New Jersey, Hudson County to be exact. We're currently building a $6.2 million housing project for veterans with the help of our donors, our partners, our supporters, and legislation. This will house 25 veterans and their families in Hudson County. We're looking to grow in numbers as the time continues. This administration right now is very helpful. They believe in veterans and veteran housing. So with our help for our current administration, we're looking to move this forward. We're looking to provide immediate stability, supportive services, independence and quality of life, and permanent housing. Again, just reiterating what we spoke about the last couple minutes, our focus student veteran advocacy. So getting these students ready and squared away, post-college, if they want to go into the military. And not only that, but kind of getting to the different transition. I meet with vets each and every day, and a lot of vets tell me that they don't have any resources outside of the military. So folks on this call, again, we're here to help you. When you do get out the reserve, out of the guard, whatever component you're in, there's a lot of resources out there, educationally and developmentally. We have a lot of community partnerships, U.S. Family Health Plan being one of them. And now, we're grateful for Reserve Organization for America, ROA, to be a next partner. We're all here to help you guys. Our goal is to build strong community partnerships. Our healthcare partners is U.S. Family Health Plan. And our biggest partner is Robert Wood Johnson, Barnabas Health. Robert Wood Johnson is the largest leading healthcare partner in New Jersey. They do a lot for veterans, a lot of veterans that are homeless. We refer them, send them out over there to help them out. Our next housing project, which will be $20 million down Ocean County, will be a partnership with Robert Wood Johnson, Barnabas Health. We're looking to stabilize and house 100 veterans by the end of 2027. Our financial partners, which are very, very involved in veteran advocacy, is Valley Bank, Elizabeth Development Company, educational partners, Seton Hall University, and the TCNJ College of New Jersey. And we have a lot of government partners here in the great city of New Jersey. New Jersey DeMava, Middlesex County Veteran Services, Mercer County Veteran Services, New Jersey Veterans Network, Community Impact and Outreach. Again, I came out of the 514th Air Mobility Wing. We did a lot of work with the FSS, Mission Support Operations, and just expanding and deepening our partnerships across New Jersey. That's our major goal, is to tackle down every base in New Jersey. We're a joint base, and every reserve and guard unit to understand what we do as a nonprofit. How you can support, simple, just volunteer time and skills, right? Again, vets don't want your money. They want your support. Attend and promote community events. Now, I know when I wore that uniform, we were briefed and told there's certain things we cannot do in that uniform. But guess what, guys? As a reservist, we're still a civilian. So I always remind our reservists and guardsmen, when you're not wearing that uniform, your weekends, give back to vets, right? There's no better time and no better feeling than giving back to the people that wore the uniform you once wore and currently wearing.
All right, we appreciate it, Tim. That's awesome. Hey, a quick reminder too to our folks that are online. We and I was the one of the worst offenders of this. As a member of the reserve component, I always saw the word veteran and assumed that that was when I was done, when I was completely done out of uniform. That is incorrect. We'll probably have a webinar at some point talking about the definitions of veterans that are out there, and ROA stance with some of those definitions and the nuance of it. But if you have served in uniform, you are a veteran in the full sense of the word. And here at ROA, we're building more of an ecosystem of things that are branded out to veterans, but are actually resources that members of the reserve component can jump in. And we've been successful in talking with many of our partners and saying, hey, can you nuance this a little bit and make sure that it's available to folks that are in the reserve component? We have many of the same issues within the RC that the veteran community has. We have unemployment, we have underemployment. Military spouses in the reserve component as well have both of those issues, as well as homelessness. I had a homeless soldier when I was in a unit out in Washington State. So we appreciate it, Tim, and locking us into some of those resources that are out there. We encourage folks that are out there across the country, take a look at what's in your local community as well. And with that, I'm going to turn it over to Jason, and we're going to nerd out a little bit on early eligibility and TAMP, two really fascinating things. And if you have deployed or will be deploying or going on an active duty period over 30 days, please listen up, and we appreciate it. And over to you, Jason.
So, guys, we're basically going to talk about early eligibility, and then we're going to jump into TAMP. I will keep this rather short. This is one of the situations I'm going to give you the info and hope that you'll reach out with your questions, because even whenever I look at this information, I was talking to Rosemary earlier, I'm like, there's so many questions you can ask to these slides. There's a lot. There's a lot of one-offs. There's a lot of situation dependence. There's a lot of unit dependent situations where even though it's on the slide, there can be some and ifs and buts to it. I want to be very clear about that disclaimer. This is a generalized statement of what happens with early eligibility. But if you have personal questions or personal situations where you're like, hey, Jason, that doesn't match what's going on, we'll have contact information available so you can reach out and talk to us directly about this, just to be clear, because I've been around a little bit, 28 years with the military Department of Defense now, so I'm aware they're always a moving part and they're not always on the same page. All right. So first, we're going to talk about phase one, which is pre-activation and orders. Next slide. So a couple big parts you have to remember is everything revolves around your qualifying life event. That's what a QLE is, qualifying life event. When that happens, that's when your 90-day plan change window opens up. So to be clear about those QLEs, that's a birth, a death, a marriage, a divorce, change of address, PCS, ETS, pre-deployments, post-deployments. Those are all what they call qualifying life events, QLEs. So if you find yourself in that window where any of those things are happening to anyone in your immediate household, that means the sponsor, the spouse, or the dependents, any dependents in your household, you have a 90-day window to make changes. Okay. Next, we talk about activating versus mobilizing. Notice says activating is distinct from mobilizing. While you will be activated whenever you mobilize, prepare to deploy, you do not always mobilize when called to active duty. We know that, right? If you've served a decent amount of time, just because you are mobilizing doesn't mean activate and vice versa. All right, so just be aware of that. It's very order specific, and when you guys get with your personnel departments, you should be able to have that conversation. Say, hey, what does this mean for me? Do I get TRICARE benefits? Do I not get TRICARE benefits? So this is the one that gets people. This can be tricky. And Stephen mentioned all his time in this has definitely evolved over the years. This 180-day benefit, that is supposed to be what you're allowed. To be clear on this, it is up to 180 days. I've had a lot of service members say, hey, Jason, I'm in the Guard. I'm about to deploy. I was told, I read online, and I see it on TRICARE's website, that I get 180 days of coverage prior to this deployment. The answer is more you get up to 180 days. There are a lot of things that play into that, and a lot of that has to do with your orders and how your unit puts them in and how you're looked at. It is supposed to be 180 days pre-activation coverage. That's what it's supposed to be. But I can tell you in my experience doing this, it just doesn't always work out that way. That's where the and ifs and buts come into play. A lot of that comes down to your unit and when they get those in DEERs. So here's what you need to understand about that coverage scope. Full medical benefits, absolutely. You'll get your medical, your dental, your pharmacy, all that stuff is covered in that time frame, which is a big plus, especially if you didn't have it or if you're paying for it. If you have that pre-activation coverage, drop your current insurance or suspend it depending on what you currently have. Pick up your TRICARE benefit and use it. Family security, right? All your qualified dependents are covered the same way you are as a sponsor, the same way if you're all on active duty. There's a no break continuation, which means, as it says here, benefits automatically remain active and seamlessly roll over when active duty services officially begins. Now, I will say I have seen cases where there is a break. There has been cases where people say, hey, for some reason it dropped my coverage, it stopped, and I was told I have to re-enroll or something happened. Yes, guys, that happens. And Stephen told us to have a big takeaway to give you guys at the end of each one of our presentations. My takeaway is going to be pretty well for every slide all the time, which is always ask and see what you're allowed to do first. Don't assume your TRICARE coverage is automatic. All right. That gets us into a lot of trouble. We get bills, we get issues. All these things happen because there's a greater assumption that, hey, this is going to be taken care of for me. When you guys are guard and reserves, it's not. So you have to do your own part and make sure you check for yourself. Check your DEERs, check your MilConnect. All right, next, phase two is just choosing your health plan. All right, so depending on your situation, you see that you have options here. If you're the service member, you guys are going to be prime remote, or remote overseas. You don't have a choice. That one is going to happen automatically. They're just going to put you into it. That's what it is. But your family is not the same situation. All right. There are choices with your family. As you see it, Select, Prime, US Family Health Plan, TRICARE Select Overseas is Prime, TRICARE for Life. There are a multitude of options depending on your situation, depending on your region, there's a lot of things to look at. So that goes back to my big takeaway. Know your situation, ask the question, what do I qualify for? Where am I living? How does this affect me? What are my benefits? Don't make an assumption that you only get one plan. For most dependents, you either get two plans or three plans to choose from, not one. That's a big one. All right. And then managing existing coverages, this is going to follow you guys. Depending on what you have, it should carry over, but you may have to re-enroll depending on if you get dropped or not. Again, your qualifying life event is what dictates what happens to your current coverage. So always check your DEERs, check your eligibility first, see if it's going to carry over. Dental, same thing with dental, guys. You all have your dental benefits. Those keep moving. Just check your enrollment, make sure nothing dropped in that time frame. Everyone, to include your family, get the dental benefit, guys. Use those benefits while they don't cost you as much as they would while on TRICARE Reserve Select or using civilian healthcare or FEHB or Fed VIP, depending on your situation, right? If you have access to the TRICARE dental program, use it. I've known so many service members who didn't realize they had that benefit. You guys get it. All right, use it when you can. All right, pre-activation success. This is what I was talking about. This is your huge takeaway. Validate your enrollment immediately. Anytime you guys have that qualifying life event, check your status. Go to your MilConnect, check with your unit. If you don't know what your MilConnect is, Google it, please. All right, you guys should know this stuff. If you don't, I'm telling you now, check it out. You got to know MilConnect. Everyone has to know it, use it. All right, this is your TAMP piece. Next slide. If you don't know about TAMP, it's a Transitional Assistance Management Program. It's very much the same thing you had prior to deployment if you have it, but now it's after the deployment. This is the big one. So I'll tell you this, I'll try to keep it really short, but I get the list of every single service member who gets on TAMP and all their families between Connecticut, New Jersey, New York, and Pennsylvania, everybody in my footprint. I get somewhere around 100 to 200 names every single month come to my desk. And Department of Defense says, reach out to these folks and let them know they get TAMP. We only get a hold of about 20% of you. And then the other 80% either are still on TRICARE Select paying for it, use civilian health insurance, or have nothing. You guys are racking up bills, getting debt, and getting all kinds of medical problems that you just don't understand why because you think everything carried over. It does not carry over. Okay? So you have to be mindful, check your eligibility, check your DARES, check your MilConnect. 1,000 times can't say it enough. Okay? That's the number one issue we're having. And that's why we have these briefings. What it looks like, it's 180 days. This one is the solid. It's not the up to, it's not the and if or buts. This is what you get. You get 180 days of medical and dental and pharmacy coverage for that whole 180 days. Now, that is based on your orders. Just be mindful, that's orders based. So even if you came back in June, but you've been home for 2 weeks because you're waiting for yellow ribbon, you're waiting for all these things to start, your orders may not be in effect yet because your unit hasn't put it in because they're waiting on the other half of your unit to come back. They can retroactive that. You'll get your coverage then. It's 180 days from the effective date on your orders that's put in DEERS. I already said this was covered. Just know you guys have it. Use it. You can also use it in conjunction with the VA if you have veterans benefits. Absolutely go get it through the VA if you can. Save you some money. If you can use it on a military base, same concept. Take advantage of your benefits. Dental, I talked about this, but I talked about it pre. Now I'm talking about it post once again. You guys have the TDP. If you don't know, there are three different types of dental programs. There's the active duty dental program, there's a TRICARE dental program, then there's Fed VIP. Depending on your service status, you should be in one of these three. Guard, Reserve, Active, TAMP. Doesn't matter. You should be in one of the three. Unless you have a phenomenal civilian sector job that gives you a really great dental benefit, then use it. Other than that, I would stick with one of these. They're pretty good options. Same thing, transition pass after TAMP. Guys, this is a big one. When TAMP expires, you absolutely have to sign up for something else. There is no automatics. There is not. And we service about 14,000 service members. Our plan does. 14,000 service members just in this local area. We do not outreach every single person saying, hey, your coverage is ending. That is on you. Now, I personally have taken upon myself to try to do the outreach. We can't reach everybody again. Sometimes I think it's 20% of all the people actually answer phones, emails, and the outreach. So that's 8 of you. Just don't respond when we try to let you know your coverage ends. You have to take it upon yourself to pay attention to that 180-day time frame. That is huge. So many of you miss out on your options. And as you see, it's TRICARE Reserve Select, CHCBP, and your civilian plan, depending on your situation. And then TRICARE Young Adult, for those who apply, we only have like 2 or 3 of those. I'm not going to dive deep. I just want you to know that if you do have somebody who falls in that category, please pay attention. All right, it's the same concept. It's not everything's automatic, guys. All right, check your eligibility. All right, I tried to keep it in 10 minutes, Stephen. I'm sorry, I got 11:45 here. I timed myself, but it's a lot of information. I know we were running out of time, but that's all I got. Thank you.
Hey, Jason, I really, really, really super appreciate that. The message about TAMP and early eligibility is anytime we can highlight those is just gold because those are so key. And for the folks that are out there in the field, if you have any piece in touching orders, getting orders as soon as possible tied directly into getting that early eligibility tied. It was a fight I fought in the Pentagon to try to get deployment orders at 6 months out so that they could tie in and get that TRICARE Prime in. As Jason said as well, it doesn't always happen. In fact, it frequently, more often than not, it doesn't. It's kind of the exception of getting that 6 months. But hey, Congress's intent for that program, which is something that ROA advocated for and got passed, by the way, you're most welcome from ROA. It's huge. Congress's intent was, hey, before you get mobilized, you're going to have that time, and that's time to unplug from what your civilian insurance is or whatever system that you have before, and plugging into TRICARE Prime. As Jason said, it's not automatic. And we've got a hand up too, so I'm going to take this question. Josh, I'm going to unmute you, and there you go. And you can plug it into the chat, or you can go ahead and sound off here.
I wanted to ask a question about ROA's initiatives. Rosemary focused a large part of her presentation on mental health burdens that are associated with healthcare coverage and the costs and availability of coverage. I'm sure ROA is familiar with this, but when our reserve members retire, federal statutes actually making that cost substantially higher, 300% higher than what TRICARE reservists are paying while they're still serving. What is ROA doing, if anything, to address that? Where's that at on the Hill?
Yes, that is a great question. And to put this into perspective, we've got this is how huge of an issue it is. I think, and correct me if I'm wrong, Josh, the cost of TRICARE Reserve now that's gray area retirees. For those of you that don't know, it's when you are done, you completed your reserve service, but there's a time period between that and when you qualify for getting a pension, which can be a long time. It can be decades. The TRICARE Reserve Select jumps from a very reasonable plan to something between $1,500 and $3,000 a month, just to enroll into the program. That doesn't include any other costs on top of that. And that's because it's largely an unsubsidized system. It's got to pay for itself, really, which makes it very, very expensive. So that is part of ROA's portfolio and our general advocacy to Capitol Hill to making it more of a benefit. It feels punitive if you're in TRICARE Reserve Select and then you get that you see that option and you're like, wow, that's not even competitive. It feels punitive. It doesn't feel like you're being rewarded for your decades of service to the reserve component. So ROA's stance is that those need to be it needs to be not only an affordable option, and this is a document that we put together earlier this year called the Reserve Component Bill of Rights, targeting exactly this. So ROA has had longstanding advocacy on fixing that problem. I don't believe that there is a bill on the Hill specifically to tackle that. And the mechanism to that would make it a subsidized system so that it gets federal dollars put into it so that it doesn't have to pay for itself. But there are options outside of that of just making it a more viable option. Because you're right, Josh, it is a credible sticker shock coming into that. It drops once you hit that, I believe, 60 and goes into a different system. But many of our folks retire at 38. They're waiting until 60 to get that. And between 38 and 60, unless they've got other options, it's not a viable option because it's so expensive. So any of our panel members want to jump in, familiar with that, anything to add?
No, I think you're absolutely correct. That is a problem we see regularly, especially, I mean, this is what I deal with. Exactly what you're talking about is what I deal with. And we pick up the transition from all those folks going to age 60. And that's when a lot of the 60-year-olds come over to us and they're like, wow, what a dramatic cost difference to go from $1,500 a month to $60 a month for the exact same coverage. They are, blown away usually by that cost difference. And it's pretty sad to hear a lot of these reservists say, I don't understand. I should have just stayed in. I should have just, kept doing the weekend a month or the whatever it is I was doing at that point in time because the benefits were better under TRICARE Reserve Select than trying to do TRICARE Retired Reserve.
Cool.
Yeah, it's 1538, I think it is. Yeah, 1548.30. It's just
Yeah. Ouch.
it's painful. Yeah.
Yeah.
And I also on this specific position, I compare what the civilian sector makes in comparison to that. And that's actually more than what a lot of civilians are paying for their health insurance for families. So it's kind of crazy. So I'm hoping one day maybe I don't know maybe the ROA can work on that too. I would love to be a part of that. Let me know. I'll jump in with you and we'll go to the Hill and fight for it. Help these guys out.
Absolutely, Jason. And we appreciate that because it's rare finding folks that have the depth of experience that you do in the nexus between how it works when you're on active duty and how it works when you're not, and to be able to talk TRICARE Reserve Select and TRICARE Prime and the actual folks that are out there executing the healthcare out there in the field as well, instead of just TRICARE umbrella. So we appreciate that.
Absolutely.
Cool. And it looks like I think we've taken all of our questions. So if we not, we'll do another screen in here. But hey, we really appreciate everyone that dialed in this afternoon. Again, we'll be doing this again today at 7 o'clock, and always looking for feedback on whether this works for folks. We are very cognizant of the fact that our members in the reserve component, you've got civilian lives that are outside of it. The vast 90% of the reserve component are not on active duty. We get it. We want to make this as convenient as it can be for you. A quick note that our next forum will be hosted by our executive director, Major General Retired John Hashem, on international programs. And then in August, we're going to talk reserve component transition. So we're not talking TAP, we're talking transitioning straight out of the reserve. Maybe a little bit of TAP. We'll talk about the DD 214-1 retirement. We will certainly talk about TRICARE options within that discussion as well. So, hey, to our panel members, we just want to thank you on behalf of ROA for helping us put this together. It was really out of your idea and our Health Affairs Committee. And Josephine, we really appreciate your assistance in putting this together, and Rosemarie and Jason and Tim joining us. We really just thank you for putting this out. And we will look forward to additional nerding out on reserve medical care issues, because we know that there's a lot of interest out there. So with that, we will sign off. And again, I appreciate it to our panel members. We will see you this evening. And for all of our members that are out there and folks that joined on, we will see you at drill. We'll see you at annual training, and we'll see you at the cutting edge of national security. ROA out. Y'all have a great day.